Imagine this. You are, you're sitting down to start your day.
Yeah.
You have your favorite mug. Your morning tea is steeping. Steam is curling in the air. It's the exact same blend you've enjoyed for years.
Right.
You take a sip, and suddenly you feel this odd, just fiery burn spread across your tongue. I mean, there's no scalding water, no rogue chili flake, just a heat that absolutely should not be there.
Oh, yeah.
Or maybe, you look in the mirror while brushing your teeth and you realize your tongue looks like a constantly shifting map with these bizarre red patches that just seem to physically move from day to day.
It is an incredibly unsettling experience for sure, because when preparing for midlife, for menopause, most of us expect the usual suspects, right? The hot flashes, the night sweats, maybe the mood swings.
Yeah, exactly.
But the clinical research shows a shocking 84% of women in one study had absolutely no idea that their fluctuating hormones could dramatically and sometimes really painfully alter the physical landscape of their mouth.
And that is exactly what our mission is for today. This deep dive is dedicated entirely to you, the listener. We are going to explore the surprising, highly sensitive, and, let's be honest, often really frustrating connection between menopause and oral health.
Absolutely.
Specifically, we're going to answer one major question, which is, why do some women experience the sudden onset of two visually bizarre and uncomfortable conditions during midlife? Specifically, geographic tongue and oral lichen planus.
Right, the big two.
So, okay, let's unpack this. Because to understand these wild symptoms, we first have to understand the cellular environment. Since our listeners already know estrogen is a systemic hormone, it's not surprising that it affects more than just the reproductive system, right?
No, not at all.
But, why is the mouth seemingly the canary in the coal mine for these hormonal shifts?
Well, the oral cavity is actually incredibly dense with specific estrogen receptors. They're known as ER-alpha and ER-beta. And they are really concentrated within the periodontal tissue and the oral mucosa. So when estrogen levels are stable, that hormone acts as like a powerful structural architect for your mouth.
A structural architect, I like.
Yeah. It continuously upregulates a protein called VEGF, that's vascular endothelial growth factor.
Oh, right, VEGF.
Exactly. And VEGF's primary job is to promote blood flow. So it keeps the vast network of microvessels in your gums and your cheeks open and thriving. And estrogen also drives collagen synthesis, which keeps the mucosal lining thick and resilient.
Right, so it's constantly signaling the body to send blood and building materials right to the mouth.
You got it.
But when menopause hits and estrogen levels drop, I imagine those signals just shut off. Does the blood flow actually retreat?
Sadly, yes. The vascular support just drastically diminishes. Without that steady stream of VEGF, the microvessels constrict.
Wow.
And without the estrogen-driven collagen, the oral epithelium, the protective lining of your mouth, it becomes atrophic. It literally physically thins out.
So estrogen is essentially the structural maintenance crew for your mouth. And when the crew gets laid off during menopause, the building just starts to fall apart.
That is a perfect analogy. But the loss of structural integrity, that's only the first domino, because there is a massive systemic immune shift that happens simultaneously.
Right, because estrogen is deeply involved in managing our immune responses too, right?
It is. It's essentially the manager that favors the peacekeepers. Estrogen typically supports a balanced immune state dominated by Th2 cytokines.
Okay, TH.
Right, which are generally anti-inflammatory. They keep the immune system calm, tolerant of the environment. But when estrogen drops, those peacekeepers lose their funding.
Oh, no.
Yeah. The immune system rapidly shifts toward a pro-inflammatory state. It becomes dominated by Th1 and Th17 cytokines.
And those are the bad guys.
Well, they're the body's aggressive attack dogs.
Okay, so you're left with thinner, weaker oral tissue and an aggressive immune system that's suddenly prone to heightened inflammation. I get the generalized soreness that might cause. But why does that localized inflammation lead to something as specific and, honestly, as visually weird as geographic tongue, rather than just typical sore gums?
Let's look at the mechanics of geographic tongue, or as the medical literature calls it, benign migratory glossitis.
Benign migratory glossitis. Catchy.
Very. So visually, the tongue normally has a rough texture created by thousands of tiny hair-like protective bumps called papillae.
Right.
In this condition, those papillae completely disappear in localized patches. You're left with completely smooth, raw, red islands, surrounded by elevated white or gray borders.
And the defining characteristic of this condition is the migration, right? I'm looking at the medical imagery from our sources here, and these patches literally move over a period of days or weeks.
They do appear to do that.
I'm just struggling to understand the physics of that. Like, are the cells physically traveling across the surface of the tongue?
Right.
Wait, so stress and a drop in estrogen can literally draw migrating crop circles on your tongue?
What's fascinating here is that it is essentially an optical illusion. It's an illusion of rapid regeneration. Really?
Yeah. The tongue is one of the fastest regenerating tissues in the human body. Its cells are constantly dying off and being replaced, so the patches aren't migrating at all.
Oh, sure.
Rather, the cellular division is misfiring in different zones in a highly asynchronous way.
Okay, I think I see.
So a patch of papillae fails to regenerate, leaving a bald spot. A few days later, that spot finally heals, but another zone right adjacent to it suffers a regeneration failure.
Oh, wow. So it's not a moving object. It's like a localized rolling blackout of cell regeneration.
That's exactly what it is.
What is causing the cell division to fail so erratically, though? Is it purely the drop in estrogen?
Well, estrogen withdrawal weakens the tissue's baseline resilience, definitely. But the misfiring is strongly linked to nutritional deficiencies that really compound during midlife.
Oh, right. Of course.
Rapid cellular synthesis requires heavy amounts of vitamin B12, iron, folic acid, and zinc. And during perimenopause, erratic or heavy bleeding can severely deplete iron stores.
Yeah, that makes sense. Plus, as we age, gastric changes just make us far less efficient at absorbing B vitamins from our food.
So the tongue is trying to rebuild its armor every few days, but it doesn't have the estrogen-driven blood flow, and it lacks the raw nutritional materials to pull it off.
Precisely.
Add the psychological stress of menopause, which spikes cortisol and further suppresses the immune system, and you get these rolling blackouts on the tongue.
Exactly. And while the medical community considers geographic tongue entirely benign, meaning, it's non-cancerous and non-infectious, the lived experience of it is anything but benign.
I can't imagine calling it benign if you're the one actually living with it. I mean, if you're missing those papillae, you have essentially lost your tongue's physical armor.
You have.
The underlying nerve endings are completely exposed to the elements.
Yeah.
Suddenly that morning tea or a vinaigrette on your salad or anything slightly acidic feels like battery acid hitting an open wound.
The sensory filters are completely stripped away. It results in intense hypersensitivity. But geographic tongue is still a localized failure of regeneration. If we look at the other condition triggered by this menopausal immune shift, we cross the line from a failure to heal into an active, destructive immune attack.
Right. If geographic tongue is the shifting map, oral Lichen planus is the immune overdrive.
Yes.
Here's where it gets really interesting. And frankly, I think a lot of listeners will feel incredibly validated hearing this because this condition can be intensely isolating.
It really can.
I mean, many women likely blame their toothpaste or their diet for years before getting a proper autoimmune diagnosis.
It is severely underdiagnosed. Oral lichen planus, or OLP, it affects roughly 1 to 2% of the population, and the demographic heavily skews toward middle-aged females.
Okay, and visually it's quite different.
Very differently than the red patches of geographic tongue. OLP often shows up as bilateral, lacy white lines.
The Wickham striae.
Yes, exactly, Wickham striae, striking the inner cheeks, the gums, or the tongue.
Calling them lacy white lines makes it sound almost delicate. But the sources note these lines frequently break down into incredibly painful, erosive red ulcers.
They do.
How does the immune system get this so wrong?
Well, it ties directly back to those Th1 and Th17 cytokines we discussed, the attack dogs.
Or the attack dogs.
Oral lichen planus is a T-cell-mediated autoimmune disease. The body's T-cells become completely confused by the altered menopausal environment.
So they attack healthy tissue.
They misidentify the basal keratinocytes. Those are the foundational cells at the very base of your oral lining as foreign threats.
Oh, wow.
So the T-cells bind to these keratinocytes and basically force them into apoptosis, which is programmed cell death.
So the immune system is actively dismantling the foundation of your inner cheeks and gums.
Systematically dismantling it. And because the immune system is already on high alert, OLP is highly reactive to secondary triggers.
Like what kind of triggers?
Well, many women in midlife are prescribed new medications like beta blockers for blood pressure or certain antimalarials for other autoimmune issues.
Right, common midlife prescriptions.
Right. These drugs can bind to the cells in the mouth and act as happens, essentially tagging the cells so the T cells attack them even harder.
Which makes it even worse.
Yeah, this creates what are known as lichenoid reactions, which are biochemically indistinguishable from OLP.
Now, in reviewing the clinical literature for this deep dive, there is a very specific medical context surrounding oral lichen planus that we need to impartially outline for our listeners.
Yes, definitely.
There is an ongoing debate in the medical community regarding its malignant potential.
Yes. And while the scientific community is still, conducting long-term studies to firmly establish the mechanics, the current data must be reported.
Right, we have to look at the numbers.
Clinical studies suggest there is a 0.5% to 2% risk of oral lichen planus transforming into oral squamous cell carcinoma.
Which is a type of oral cancer.
Yes, over a 5 to 10 year period.
Now, we aren't taking a stance on the severity of that risk, but it clearly explains why a diagnosis of OLP fundamentally changes your relationship with the dentist. The clinical guidelines in the sources are incredibly strict about continuous monitoring.
Having a specialist examine the tissue every 6 to 12 months is the absolute standard of care.
Wow. Okay.
Because the basal cells are under constant inflammatory stress, spotting any dysplastic or abnormal cellular changes early is paramount.
It makes complete sense. So we have the rolling blackouts of regeneration in geographic tongue and the active T-cell destruction in oral lichen planus.
Yeah.
But the sources point to a third factor here, a catalyst that takes both of these conditions and amplifies the pain exponentially during midlife.
Xerostomia.
Which is the clinical term for dry mouth.
Exactly. And dry mouth sounds like such a minor, dismissible annoyance.
Yeah, like you just need a glass of water.
Right. But structurally, if you have exposed nerve endings on your tongue or erosive autoimmune ulcers on your cheeks, losing your saliva is devastating.
I keep picturing running down a slip-and slide, but someone suddenly turns off the hose.
Oh, that's vivid.
Without the water, the sheer friction of the plastic is going to tear your skin apart.
The physical friction of speaking and chewing without lubrication is agonizing, but the chemical reality is even worse.
Wait, chemical?
Saliva is a highly complex antimicrobial pH balancing fluid. It contains powerful buffering agents that neutralize acids.
Okay, so it's not just water.
Not at all. And up to 70% of postmenopausal women experience xerostomia. And it is intrinsically linked to a sharp decline in what endocrinologists call salivary estradiol.
I'm curious about the actual plumbing of that. How does a hormone floating in the bloodstream dictate how much moisture a salivary gland produces?
It all comes down to cellular transport channels called aquaporins.
Aquaporins.
Aquaporins are essentially microscopic water gates located in the membranes of your salivary glands.
Oh, okay.
Estrogen transcriptionally regulates the expression of these gates. It basically tells the body to build more of them.
So when estrogen levels plummet,
the number of aquaporins drops drastically. You simply do not have the physical channels to release water into the mouth.
So the fluid volume plummets. And I'm assuming the fluid that does manage to get through those remaining gates is fundamentally altered.
Completely altered. Without the volume to carry those buffering enzymes, the entire ecosystem of the mouth collapses.
Wow.
It becomes a parched, highly acidic environment. Opportunistic bacteria thrive, which drives up the risk of rapid tooth decay.
Right.
But for someone with geographic tongue or OLP, that acidic environment acts as a relentless, caustic irritant.
So you're sliding down a dry slip-in slide that is essentially coated in acid.
Pretty much.
The physical friction of your teeth against your cheeks, combined with the chemical burn of unbuffered saliva against those ulcers. I mean, it's no wonder women are waking up in agony.
That's terrible.
Which makes me wonder about treatments. If the lack of aquaporins, the immune shift, and the cell death are all systemic issues rooted in hormone loss, are localized topical fixes like changing toothpaste, just putting a Band-Aid on a gaping wound?
Well, that is the pivotal question of midlife oral care. You really have to address this from two directions simultaneously.
Oh, yeah.
Top-down systemic stabilization and bottom-up local protection. And the scientific literature provides some very compelling, evidence-based pathways for both.
Okay, let's look at the top-down systemic approach first. If the root is a lack of estrogen, does hormone replacement therapy actually reverse this specific damage?
The clinical data on HRT for oral health shows profound, sometimes variable, results.
Okay.
By stabilizing systemic estrogen, HRT effectively brings the peacekeeper Th2 cytokines back online.
So it calms down the attack dogs.
Yes, calming the T-cell attacks in Lichen planus. It also reactivates the VEGF pathways for blood flow, and crucially, it stimulates the salivary glands to rebuild those aquaporin water channels.
Oh, that's huge.
Yeah, for many women, HRT restores the baseline ecosystem.
But HRT isn't an option for everyone, right, depending on their medical history.
Right, exactly.
If we can't replace the estrogen, how do we systemically support the cell regeneration?
This is where targeted nutritional therapy becomes absolutely vital, supplementing with high-quality, highly bioavailable B vitamins, iron, and zinc.
So giving the body the building blocks it needs.
Exactly. It provides the exact raw materials the tongue needs to fix those regenerative blackouts we talked about earlier.
Okay.
But the most fascinating systemic intervention in the recent literature involves alpha-lipoic acid, or ALA.
Alpha-lipoic acid. I've seen ALA mentioned in the context of nerve pain before.
Yeah.
How does it work in the mouth?
ALA is a highly potent lipophilic antioxidant, which means it can easily cross cell membranes.
Okay.
The exposed nerve endings in geographic tongue and OLP are bombarded by reactive oxygen species,
Reactive oxygen species.
basically inflammatory waste products that cause that intense burning sensation.
Ah, got it.
ALA actively scavenges and neutralizes those reactive molecules directly at the nerve site,
Ah.
significantly lowering the perception of pain and burning.
That is incredible. So you're structurally provided the building blocks with B vitamins and turning down the nerve alarm bells with ALA. What about the bottom-up local approach? What can a listener actively change in their bathroom routine tonight to stop aggravating the tissue?
The immediate priority is removing chemical stressors because your natural defenses are completely compromised.
Makes sense.
You must aggressively avoid dietary triggers, highly acidic citrus, sharp, spicy foods, and alcohol, which is a potent astringent that will further dehydrate the mucosa.
Oh, right. Alcohol dries it out more.
But the most critical immediate change is auditing your toothpaste.
Ah. You're talking about sodium lauryl sulfate, SLS.
Yes. SLS is a surfactant. It's the chemical foaming agent that gives traditional toothpaste that sudsy, clean feeling.
Right. Everyone loves the foam.
In a younger mouth with a thick, estrogen-rich mucosal barrier, SLS is generally tolerated just fine.
But not in menopause.
No. In a menopausal mouth where the oral epithelium is thin, atrophic, and lacking protective saliva, SLS is devastating.
Oh, wow.
It actively strips away the microscopic lipid bilayer of the remaining cells. It directly exposes the inflamed nerve endings to the environment.
It's basically pouring a chemical degreaser on an open wound.
Precisely. Switching to an SLS-free, natural, unflavored toothpaste removes a massive daily inflammatory burden from the tissue.
That's such an easy fix, too.
It is. And for those dealing with the severe ulcers of oral lichen planus, dentists will often prescribe localized topical corticosteroids or immunosuppressant rinses.
Okay, to treat it right at the source.
Right. These bypass the systemic immune system and shut down the aggressive T cells directly at the site of the Wickham striae.
So what does this all mean? It means there might not be a single overnight magic cure that makes the sensitivity vanish instantly.
No magic cure, sadly.
But there is a profound, life-altering power in simply understanding the mechanics of your own body.
Absolutely.
By realizing that your shifting tongue map or your burning lacy cheeks are documented, cellular reactions to menopause, you take away the fear of the unknown.
Yes.
You aren't crazy. Your daily cup of tea didn't suddenly turn toxic. It is simply your biology experiencing a structural shift, asking for targeted support.
If we connect this to the bigger picture, the real tragedy of menopausal oral health is the silence.
Yeah, people just don't talk about it.
Countless women endure the social isolation of not being able to enjoy a meal out, or they just dismiss their daily pain as just part of getting older.
Right.
Understanding this specific biological cascade, from the loss of estrogen receptors to the T-cell immune shift, down to the collapse of the aquaporin water channels, it equips you with the exact language you need.
Which is so empowering.
It gives you the tools to advocate for yourself effectively when you sit in the dentist's chair or consult your doctor.
It really is a journey of connecting the dots. We've tracked how the localized loss of cellular estrogen and a shift in aggressive immune cytokines manifest as those migrating tongue blackouts and lacy immune-driven ulcers.
Yeah.
And it's all magnified by the sudden loss of our saliva's protective aquaporin channels.
The systemic connection forces us to reframe how we view oral health entirely. It is not an isolated discipline.
Which brings us to a final thought I want to leave you, our listener, to mull over. We traditionally view our teeth, our gums, and our tongues strictly through a very narrow lens of dentistry.
Right?
We think about the mouth purely in terms of brushing habits, flossing, and avoiding cavities.
The usual checkup stuff.
Right. But given how dramatically and rapidly the tissues of the mouth react to fluctuating estrogen, nutritional dips, and systemic immune changes, what if your mouth isn't just a separate anatomical room for your dentist to clean?
Hmm.
What if your mouth is actually the most sensitive, real-time barometer for your body's overall hormonal and systemic health?
This raises an important question for all of us to consider the next time we look in the mirror. Are we listening to the signals our body is broadcasting?
Exactly. So tomorrow morning, when you sit down with that cup of tea, I hope you take a moment to appreciate the incredibly complex, reactive ecosystem that allows you to taste it, feel it, and enjoy it.
Beautifully said.
And if you or someone you know is navigating the strange, uncharted waters of midlife oral health, please share this knowledge with them. Let them know they are not alone and that there is a cellular reason for what they're experiencing. Keep exploring, keep asking questions, and we will catch you on the next deep dive.